the big disclaimer is that if you don't do ADR, this talk is not going to make you an expert in ADR, so I do apologize, but I will try to go over the basics. In general, when you have an unambiguous cap, a good landing zone, and we look for interventional collaterals, lack of interventional collaterals, having a good landing zone and a clear proximal cap typically tends to favor an antegrade dissection reentry approach. This is like, we had a very interesting talk on algorithms this morning, I think, by Dr. Surya Prakash Rao. The bottom line is that you can use any algorithm but have a method to the madness. You need to know where you're going in if you're going to go antegrade, so unambiguous proximal cap helps, and a decent landing zone always helps. So these tend to favor an antegrade dissection reentry strategy. And why dissection reentry and not wire escalation? Because typically penetrative wires tend to go straight. And I think this slide has been made fairly popular. So using a knuckle or some kind of a strategy to leverage the subintimal space to get to the reentry zone works in our favor, right? Because we have reliable ways of getting back into the true lumen. And whether you use a knuckle, Mongo wire, XT, crossbars, doesn't really matter. Get to the reentry zone and then work on reentry. This was, again, a couple of years ago when we believed that using a crossbars would kind of create a very tight subintimal space, which would increase your chance of reentry. And then the only tool that was really available was the Stingray balloon. I still think it is the best tool for targeted reentry, where with 1 millimeter precision, you could re-enter from the subintimal space back into the true lumen. And again, this is just to tell you that most of the current algorithms do incorporate ADR as one of the strategies, including the Asia Pacific CTO Club algorithm, the Chinese algorithm, the EuroCT algorithm, and the global algorithm. So in essence, right, like what you want to do, I'll just get here. For those that have not seen the crossbars, I've not used one in a couple of years, but in case you're interested, it does have an atraumatic tip. It's 1 millimeter, and you essentially spin really fast to get to the reentry zone. Typically works well with a tapered cap, not with a blunt cap. You want it to be a couple of finger breadths away, and you spin really fast. And this just reiterates that it doesn't really work well with a blunt cap. And once you're through, you can, now what we do is use a microcatheter, a penetrative wire, get into the subintimal space, typically use a knuckle. You can use a trap liner or a guide extension catheter to prevent the subintimal space from being exposed to the systemic pressure. And we still don't have the trap liner in India, so you could use a guide extension catheter. I don't routinely do this. And you could use a crossbars for just getting to the reentry zone. And once you're here, you really want to be in positions 4 or 5. You can, if you're in 5, it's done, because now you can just pass a wire into the true lumen. If you're in 4, you can use a Stingray typically to re-enter into the true lumen. Just a point to note, I know we know once you're in the subintimal space, you don't want to inject. A good habit would be to just remove the syringe so that inadvertently you don't inject. How you get to the landing zone doesn't matter. Like I said, knuckles or crossbars either works. This, again, was a slide from a couple of years ago. The idea was that there is less true lumen compression with crossbars compared to a knuckle. That just illustrates the point. Again. So this is, I hope this plays. Okay, I guess it does. So you just spin it really fast, and this was actually from, I think, 5-6 years ago when we still, I think it still used crossbars a fair bit. And once you are there, switch. And the key point that I want to say is that preparation of Stingray balloon matters. It's on YouTube. Manos has multiple videos on this, or you can just ping one of us and ask us how you want to do it. Prepare the Stingray balloon well, then advance the Stingray balloon to the reentry zone. Typically, this is done over a miracle wire or some wire that's stiff all the way to the tip, because it's not, despite being low profile, it's not a very deliverable balloon. It's seen as 2 radio opaque markers. You can do straw, which is aspirating through the back end of the Stingray balloon catheter. And then you want to get the right position, which is as shown on the left, which is the optimal view. The railroad tracks you do not want to see, because there you do not know which hole to take. The holes in the Stingray balloon catheter are 180 degrees apart between the proximal and the mid. One will be towards the true lumen, the other would be outside the vessel. And yeah, this just, move your eye till you get the right orientation, then stick. I can just see his play there. Just going to let this play for a second. This is not a subtle act. You actually are sticking in. And again, this is how it looks once you take it out. You see that it actually goes through the side port, right? And then, you routinely used to stick and swap. These days, I tend to stick and drive a lot more. Again, there you go. So what has changed? You don't use crossbars that much. You can go lower profile. I think in Asia, most of us use 7 French, not 8. The LP delivers a little bit better. You could re-enter with any number of wires. The key is it's got to be penetrative. You could stick and swap or just stick and drive, and use straw routinely. And there are multiple problem-solving algorithms within the algorithm itself. We don't use wire-based ADR unless you're just doing subintimal plaque modification. And I think the number of operators has really widened, and we have people from all over the world now doing it. And so just a snippet, I think maybe I have a few more minutes left. I'm just going to show you a couple of cases. This was a case from last year, and it's a RCA CTO, which is pretty long. My plan was to actually do reverse cart here, and one of the challenges that I have a lot of appreciation for the Indian operators now, myself included, which is like you have to have one other constraint. It's not just radiation contrast, patient risk, blah, blah, blah. It's also finances. So we do have to be judicious about how we use it. So here, what we did was, I do apologize for the patient name being there, but hopefully it's confidential, and we are all healthcare providers here. So I have a knuckle being advanced, and you go further down, and so this is a Corsair and a knuckle. Be careful not to advance the knuckle beyond the re-entry zone. And as you can see, actually here, I'm re-entering before where I actually see the vessel. And again, I wouldn't advocate this as your first case, but I was supposed to show challenging cases, so there you go. And this was just a stick and drive, and we confirmed that we were in the true lumen, exchange for a workhorse wire, stented, and actually it was done within like transmission time. Here's another case, which was actually at Dr. Goel's lab a couple of years ago, where I had the fortune of working with another expert. This was a CIRC CTO. What was challenging about this case was there were two different schools of thought, really. But really, this case had no retrograde options. As you can see, it's a CIRC CTO. The plan was to do an IVAS guided entry, but then really work on, if AWE doesn't work, to go retrograde. If that doesn't work, to then switch back to some kind of an antigrade strategy. We were able to successfully penetrate the proximal cap as shown there. You can see around 10, 11 o'clock that we penetrated at the right spot, but be it as may be, just couldn't wire it. And then no retrograde options. As you can see, the wire is all over the place. Nowhere close to the segment. So we agreed to knuckle at some point, knuckled, got it down, caravelle. What was challenging here was it was a double blind stick and swap. So essentially got the stingray. Typically we don't take pictures, but we kind of did this here because there were no collaterals from the right, and it was a live case, and we just wanted to be sure everyone was on board and felt it was safe. This was obviously proximal to the bifurcation of the obtuse marginal. This was a stick and drive, like pretty much 30 minutes after we decided to knuckle. Got into the true lumen, wired the other branch also with a crusade, confirmed that we were true lumen on both with IVAS, as you can see from 12.1, true lumen. Further on, it'll be subintimal, and more proximal, it's again true lumen, and this was the final result. This was another case, low EF. Many patients in India can't afford Impella. So one of the strategies that, and sometimes it's the last remaining vessel, so going retrograde really makes the ischemic burden super high. Patients are unable to tolerate it several times. So I have a low threshold for doing ADR in these cases. So this is how it started, and it was all viable, otherwise we wouldn't have done it in the first place. So as you can see, that's an ugly knuckle going down all the way. Really diseased re-entry zone, re-entered. This was the final result of the LAD. And actually the EF did improve, I think, from like 25 to about 40, 45. This was, I'm going to skip this in the interest of time because it's a little longish case, but the long and short, I got a minute, right? Okay. So this was a case where, again, honestly, I thought it was going to be easy, but someone had tried and failed, which always should make your, antenna go up. So proximal cap was visible, super short segment. So this really goes to tell you any case can be challenging, right? And this was short, calcific, prior attempt failure. So plan was AWE, retrograde. if nothing works, ADR. So I had to blow through my first options pretty fast, although I had a ping pong guide, I had a retrograde wire, I had already externalized the wire, but I could not get a microcatheter across, so I actually tried external cap crush, didn't work, but then I was all set up for ADR, so essentially just used the retrograde wire as a marker and did basically an antegrade dissection reentry where we circumvented that one area which was a problem area. And not sure why this doesn't play, but hopefully this plays. It's not playing. I'm not sure why. And this is just still images again. This was CTO Live 8 this year, post-bypass. Again, what I really want to emphasize is that ADR has this stigma around it, that it's hard, that the learning curve is very steep. Yes, yes, and yes, but I think it's important that you learn it because in this case, I'll tell you, this was the last remaining vessel. It's a diseased vein graft that has been stented multiple times with restenosis, was actually referred by another cardiologist from another city with really no other options. And the patient can't, I mean, if I have to go use this as a conduit to go retrograde, the angles weren't favorable, plus no chance of impella once again. And so this ended up being a blind, I mean, not a blind, but I had to re-enter well before I could actually see the vessel, and was a stick and drive, and that was the final LAD result. So in conclusion, I think it's important that we learn how to manage hematoma. How you cross the CTO segment doesn't really matter. Make sure you limit the system, limit the subintimal space's exposure to systemic pressure, and definitely don't inject antegrade, refrain from that, and good luck in your CTO endeavor. Thank you very much. So just wanted to put this up for those that are interested. Tomorrow we are doing a live case from my hospital for AP CTO Club. There's also another course for those that want to learn from the basics, the CHIP CTO course, last week of January. So be sure to attend it. You have a stellar panel, so I would really encourage those that are interested in attending the course. Thank you.